Okay, thank you everyone for joining. And just briefly, this webinar is brought to you uh, by the Nepal Public Health Foundation and Global Health Network, University of Oxford. I'm Kusum Thapa. I'm the chairperson of Saptakosia Hospital and the president-elect of the South Asian Federation of Obstetrician and Gynecologists. I'm delighted to be joined today by Dr. Swaraj Rajbhandari. So briefly, before I begin and before I really introduce Dr. Swaraj, let me just start off with a little bit of a housekeeping. This webinar will be recorded and will be shared to you all by the Global Health Network of Nepal. To automatically translate the speech, what you need to do is write down in your bar, you will see a show caption, which is circled here. So if you can click onto that, then you can click onto whichever language you would like to listen to. There are a lot of participants who have been registered, so your video and microphone have been disabled. Please use the chat function to introduce yourself and also to report if there is any technical issues. Once the session is started, the chat function will be sort of disabled, and we would like you to put your questions in the Q&A function. So please post your questions in the Q&A function box. And there will also be opportunity to make verbal contribution at the end of the session. So you will be able to raise your hands and we will unmute you during that time. So this is interesting that we have had a global representation. And if you can see on your screen, the total we have 529 participants from different parts who have registered. Please continue putting your introduction in the chat box. So the basic objective of this webinar is basically to explore the role of telemedicine in obstetrics and maternal care in Nepal. We will also be discussing and we'll hear from Dr. Swaraj the challenges and opportunities of telemedicine in Nepal. She's had great experience with that and she will share that with us. And also to provide insight on the impact of telemedicine on rural healthcare access. So briefly, I would really like to introduce Dr. Swaraj Rajbhandari. She is the Chief Obstetrician and Gynecologist at the Helios Hospital. She is also an advisor of the Society of Nepal, the Midwifery Society of Nepal, and the Chief of Maternal and Neonatal Department in the Nepal Public Health Foundation. She has extensive experience, as I mentioned earlier, in clinical practice and international public health, and has led implementation and integrated reproductive health services across the globe, spanning from Asia, Africa, the Caribbean, Pacific, and Middle East. She is the founding member of the past president of the Society of Obstetricians and Gynecologists and Menopausal Society of Nepal. She's an accomplished author, peer reviewer, contributing and leading to lots of journals, and she has a lot of accolades in her name. A highly recommended and regarded speaker and a panelist at Global Conference. And if you remember the Align MNH, she also served as the steering committee member for that. So I could really go on with all the awards and recognition she's had, which you can see in the screen in front of you. But for the sake of time, then I will just hand over to Dr. Swaraj. So over to you, Swaraj, for taking us through this very, very interesting topic of telemedicine, which is just the most needed thing for us at this present time. Over to you. Thank you.
Namaste. Good afternoon, good morning, and good evening. I think many of our colleagues are from USA and UK and many different parts of the world. Thank you, Kusum, for that kind words. It's a great pleasure to be sharing our experience from Nepal regarding telemedicine. I think during COVID, all of us, we learned how to do the teleconsultation, telemedicine. I think this is what I'll be sharing in next 35 minutes or so. All right, welcome all of you to this telemedicine obstetrics session. Um, the way I'm going to present, Kusum has already highlighted the main objectives of this session. The way I'm going to present is that I'll give you the brief background of the health situation of Nepal, and then what is the scenario, what is the number of the service providers, plus with the population, etc. And then I'll come to the telemedicine, and then what was the rationale, what are the benefits, what were the challenges, and what did we accomplish during this time. I think that is I'm going to share in next 35 minutes or so. Many of you who do not know Nepal, Nepal is a federal democratic republic country, is a landlocked country between China, India. We are landlocked in all three sides by India, and on the north is China. And we have a total population of almost 30 million. And then we have ecological regions, mountains, hills, and Tarai region. We have 7 provinces and 77 districts and 753 local level governments. Our life expectancy has increased, and our female's life expectancy is 73. And this is to give you the snapshot of the health services available in Nepal. As you can see on the right-hand side extreme, the lowest cadre are female community health volunteers. They are volunteers, and they are available more than 50,000 in country, and they are kind of the pillars of our health system. Above is the picture of the primary healthcare outreach services, and the building with the blue roof is a primary health care setting, is the health post where the birthing center, the most of the delivery in the remote areas occurs there. Central on the top is the district hospital. This is kind of the latest design of the district hospital, and not all the district hospital will provide the comprehensive emergency obstetric care, but most of the places it is available now. Below is the maternity hospital, which is the tertiary care center, one of the largest tertiary care center for the maternal health. Earlier, this is the only maternity hospital, and where I have spent, and Kusum have spent more than a decade of our life. And the extreme right, you can see the Kathmandu, the medical colleges, the new medical colleges, whether it's the government or the private. And on top, you will see the institution like BPKHS, which is, medical colleges. Now, Nepal has more than 20 medical colleges all over the country. So this is to share that Nepal has, taken a great stride in terms of maternal and the neonatal health, where we have really decreased maternal mortality from 539 to 151 in 2021. That was a drastic decline, but to reach the SDG target of 70 looks a bit challenging to us. Let's see what are the condition, what are the causes of maternal death. Is the now you can see that non-obstetric complication like that is taken the top regarding the maternal death, and obstetric hemorrhage remains one of the major killer. And if you see that where is this? The maternal deaths are occurring in postpartum period, especially after delivery or during delivery, also 33%. And this is, again, another fact that the most of the deliveries are occurring in the health facilities. We can discuss that later, why it's happening. Now, this is to show that trends in early childhood mortality is, I think we are doing pretty good in terms of the child health. The mortality has been reduced, and we are hoping that we'll be able to achieve that, the SDG. However, there is a challenge for the neonatal mortality rate, because I think it has been stagnant from 2016 to 2022, and it seems like we really have to struggle to reach the target for the neonatal mortality rate for various reasons we'll discuss later. Now, the place of delivery has tremendously increased. To the health facility delivery has increased. Now it is 79%, which is very encouraging, and almost 80% are delivered by the skilled healthcare personnel. This is particularly, I wanted to share that what is the scenario of healthcare providers in Nepal. The Lancet Commission recommends using the density of a specialist surgical workforce for monitoring universal access to safe, affordable surgical and anesthesia care. The target is to have 20 specialists per 100,000 population. But a study by Ross et al. In 2023 conducted in 25 remote districts of Nepal found that the specialist density was very, very low at 0.4 per 100,000 for the whole study population. And this is published recently in a journal, Euro-Asian, in 2024. I had put the citation, somehow it got deleted. Now, this is the picture I wanted to share that, to a visitor, to a tourist. It is a beautiful country with the mountain hills and the Tarai. It is the green hills and snow-peak mountains. It looks lovely. But think about a pregnant mom, a woman who is in labor, to walk all this difficult terrain, to cross this this bridge, hanging bridge, is quite a challenge, right? It's a quite a we can't think of that. Now, especially during rainy season, the broken bridge, landslides, I think it takes a toll, and it is very difficult for a pregnant mom to reach the health center. Sometimes these are the unmanaged resources also is a problem, and these closed health facilities also pose a problem to the mom and the baby. Now, to talk about telemedicine in Nepal, I think first time in the world the telemedicine was done in NASA to talk to the astronauts via satellite. And same is in telemedicine Nepal. It was introduced in 1998 to reduce casualties from the mountain climbing by monitoring vital signs at the Everest Base Camp through satellite connection with Yale University. And their rescue system is pretty good. They have got trained paramedics when they go to rescue. Now, in 2010, Ministry of Health and Population started in 2 remote district hospitals of Nepal, which was expanded to 20 districts. So I have to introduce this amazing guy, Mr. Mahabir Pun, who is responsible to establish this technology in Nepal. And especially, I have had an opportunity to use this technology while I was working in Kathmandu Model Hospital. And this is to talk, discuss between the doctors and from the district hospitals to the bigger hospitals, and even internationally, when we have problems, we used to discuss these cases. And I also would like to take a name of Mr. Rajendra Paurel, who developed an app called Amakomaya, with whom we are working in our another project in Kapil Vastu, another research going on. So this Amakomaya is that you can enroll all the pregnant moms, and they can consult with the nurses or midwives by telephone. The good news is that we have guidelines for telemedicine services in Nepal, which is again backed up by the Nepal Medical Council in 2020, and this national e-health strategy was published in 2017. So at least in paper, we have things in place. So what is the proposed federal proposed implementation of telemedicine services is that there will be a central hub, the bigger hospital, medical colleges, teaching hospitals, and the provincial hub, like I had shown earlier, that we are the federal structure, we have federal government and the provincial and the lower level government. So I think in picture, it looks very appealing that we have things in place, but it is not being implemented systematically. So here, the pregnant woman being the center, they can do the virtual pregnant care visit at home, the blood pressure monitoring, fetal heart rate, blood sugar, everything can be monitored. The counseling can be done. Mental health care can be, counsel, virtual postpartum visits, and lactation support. That is a very important points, and it can be done by telephone. And this has been implemented in many countries, especially in developed countries. I think radiologists and other field which is not like a not in emergency. I think most of the cases are many cases are done in by telephone. But it is until COVID-19 happened, this pandemic resulted in a significant increase in the reliance on telemedicine and telehealth for provision of healthcare services. Now, this shows that those people who were on home isolation, they could contact in these numbers given here. It's in Nepali, sorry. But the Minister of Health has put this information that they can contact from morning 6 a.m. to evening 10 p.m. if they have such and such symptoms, and they need to contact the service providers and the health facility. So with this, during COVID, what happened? Uh, the lockdown imposed the lockdown imposed affected the transportation services, as in many countries, and reaching to the health facilities and referrals were impacted. It created significant barriers in MNS service utilization, and studies showed that there was 50% decline in health facility delivery. So with this, the Family Welfare Division developed interim guidance for reproductive, maternal, newborn, and child health services in the COVID-19 pandemic, and highlighting use of telephone consultation as one of the strategy for providing services. Aligning with the government strategy, One Heart Worldwide developed an MNA service emergency helpline to support the service providers working in the remote districts of Nepal. Now, the objectives of this helpline program, I mean, it's a telemedicine, but it's not a fancy, we don't see the, television, or we do not talk in that satellite manner, but it is the simple phone helpline program. And this is like to do the real-time clinical advice to the service providers working in remote birthing centers. And this to bridge the gap between pregnant women, service providers, and health system by developing a communication system. I think communication is the key about the telemedicine. And few points about One Heart Worldwide. I was advisory board member for Nepal program, and also technical advisor. And when we conducted this research, I was with One Heart Worldwide as a technical advisor. So this is One Heart Worldwide is a non-profit organization focused on improving maternal and child health in remote areas, particularly in Nepal. Since 2010, One Heart Worldwide programs have impacted over 1 million mothers and newborns throughout 32 districts of Nepal. So the work model is to strengthen the health facility, especially birthing centers, and to train and update their knowledge and skills, all the healthcare providers, and bridge a gap between the community workers and the even do counseling advocacy at the community level also. So this shows the program initiation. The family welfare, we had to take approval from the different departments, family welfare division approval. We also took approval from Research Council, and the memorandum of understanding between One Heart Worldwide and the Nepal Society of Obstetricians and Gynecologists was signed. And then in various stages, the orientation was given to NESOG members, district experts, and to the nursing staff. There was a distribution of referral flex, and the regular meeting with NESOG members and district experts were conducted. And after each management of each complicated cases, we used to do the debriefing. Now, the project description is like for each district, 3 to 5 experts assigned, 3 gynecologists, and if available, 1 or 2 MDGP from district hospital. The important point was that the phone number of 4 experts provided to service providers, and additionally, the mobile top-up was given to them, about $2 per month. And then the guidelines was developed so that they know when to call, what are the cases to call, and then this was oriented to all service providers and experts. Also, the orientation on airlifting process and referrals were provided, and to strengthen the referrals, the flex containing contact details of vehicles, ambulance, referral centers, and concerned stakeholders was also provided. So methodology is like we use the mixed method using both quantitative and qualitative data. Time period was July 2020 to June 2021. The variables used were type of cases, reasons of consultations, and outcome of consulted cases and means of transportation. Telephone interviews conducted for this qualitative research with clinical experts and service providers in July 2021 to uncover the perceived benefits and usefulness of helpline and challenges faced by experts. Studies sites were 14 districts, study population were service providers and experts. So this study was conducted, as you can see in the map, covered by the blue, is where the 14 districts where the One Heart Worldwide was supporting the government, and all the birthing centers of this area, 551, was covered. Regarding the data collections, it was the nurses' telephone logbook review. This was all prospective data collection, and One Heart Worldwide district staff collect the data from nurses as per their logbook and enter in Google Sheet. Phone interviews by research assistant was kind of retrospect data collection because they had to speak to, they called all these 551 health facilities to ask whether the nurse had used MNH helpline, and if yes, how many cases were consulted in last 1 year. In qualitative data, in-depth interviews with the experts, gynecologists, and MDGPs, and in-depth interviews with the nurses were like, there were 4 categories. One category never used helpline, second category, they used helpline only once, and third category was like they used more 2 to 5 times, and fourth was they used 6 times or more. Now, the quantitative data collection was also like the vehicle logbook data was collected for the referred cases, and the from this logbook, they were asked to fill, the nursing staff fill that logbook, which include travel from place to travel to place and cost incurred in travel. And the average cost spent in travel was also calculated. So let's see what are the findings. The month-wise number of cases consulted using MNH helpline from these 14 districts were 429. And as you can see in this slides that some of the districts did more, like Dhading, Dolkha, Samkhwa Sabha, Sindhu Palchok. These districts made more calls because they are more remote and they don't have, access to the district hospital nearby. Now, this will give the picture that when we introduced the program in July, suddenly you can see the peak there in August, because this was the time of lockdown, and also this was the rainy season, and most of the time the road blockage, the broken bridges, and all those things really gave this picture, and slowly and gradually the number decreased. And here you can see a kind of a plateau, because I think the lockdown was for the short duration. It opened up, and it's the winter season, and the roads are much better then. And again, like second lockdown started, and then you can see the pickup. But we collected data only from July 2020 to June 2021. So what are the types of cases consulted? Where like maximum number of the cases were for during delivery. Of course, during delivery they have problem, and 28% were for the antenatal care, and the newborn 12%, and PNC was 2.6%. The type of cases consulted was mostly prolonged labor, eclampsia, preeclampsia, and then post-rated pregnancy, retained placenta, postpartum hemorrhage, birth asphyxia, breech presentation, preterm labor, preterm baby, and out of all these cases, 2 were PCR positive. Also, it was analyzed that how many cases they consulted at the district hospital, how many with the primary healthcare center, and how many they call the NESOG expert pool. So you can see that district hospital and NESOG pool member, I think almost the similar percent they consulted, and primary healthcare center were 13%. And this is very encouraging, this slide, that after the consultation, the nurses were able to manage inside the health facility, that is 21%. That is quite remarkable. Otherwise, they would have referred those cases. And the referral cases were 79%. Out of these, 20 cases had to be heli lifted, where all the 18 mothers survived, but 2 neonates who were heli lifted also, we couldn't save them. And among all these delivery cases which we have recorded, there were 24 neonatal deaths, 3 stillbirths. Now, what are the means of transportation? Is like a number of 313 cases were referred. So ambulance and hired vehicle, I think it is the similar percentage, almost 30%. And they also used public vehicle. Heli lifted was 4.7%, and one patient was taken on a stretcher, one was on truck. And the average cost spent on transportation is like a 5,118 that time, at almost like a $50. Now let's see the qualitative findings based on in-depth interview with experts and the nurses. Uh, these are the experts' perspectives. What are the effectiveness of MNH helpline? It saves lives of the mother and the newborn. Even the case of retained placenta, excessive bleeding, PPH was timely referred and saved her life. And some cases were managed within the health facility, like even the PPH was managed by the consultation. Breech was delivered by video consultation. If there was no progress, although the lower health facility was not supposed to augment, but then, at night, there was no way that they could send the patient. So, with the consultation, with the virtually all these things, they made a good progress. And obviously, I've already mentioned timely referral, avoid delays, and that the consultation really build the confidence and skills of the nurses. Now, these are the quotes from nurses, that the consultation helps in taking decision, and that increased the trust of the patient party, because then they could say that we spoke to a doctor in the district hospital or a bigger hospital, so their suggestion is to do this, this, this. So that really, patient party were really happy that, okay, do whatever you got the suggestion. And if they are managed in the same health facility, I think it really saved their time and they were very happy. So what they felt is that helpline helped by providing doctor to our hospital. Even if they are not physically present, at least they were able to even call around 1 a.m., even early morning, so that, they felt that they were really supported. Now, what are the reasons for not using MNH helpline? This is quotes from the nurse. Again, like this is from the program perspective, it is very important to continuously do the orientation. In spite of that, there were like 10 nurses said they do not know about the MNH helpline out of 28 nurses interviewed. They were not included in the training. Either they were on leave or they were new in the health facility. And some people said that nearby district hospital and primary healthcare center is so near, so we didn't want to take risks, so we referred and we didn't call the helpline. And then some said that their mentors, SBA mentors, were very close, and we could call them and we could take their suggestions. And some said we didn't encounter any complicated cases, so didn't call. So that's fair enough. Reasons for using helpline only once, because Again, like they thought they could call only during emergency. And also like if they called once or twice, the expert didn't answer. If they didn't hear, if the doctor didn't call back, I think they felt they didn't feel comfortable to call back again. And the poor network is another issue that they couldn't make a timely call. Now, these are some of the implementation challenges from the program perspective. Um, I think the reporting documentation is an issue. Very few reporting by experts, and change in the district hospital experts is also we thought that was an issue, because then every time you have to kind of orient the new person, and the under-reporting. Sometimes the one had district staff also, because of the busy schedule, they also could not collect the cases, and there has been under-reporting. And coordination with referral centers is also at times is challenging. Now, some of the challenges mentioned by experts is that lack of essential drugs and medicines. Uh, Despite some life-saving drug cost only 15 rupees, it was not available at health facility. I will share that there was a case of PPS. I asked them to say that, okay, start the oxytocin 20 units in the saline and then give tranexamic acid, and they had only one ampule. So you need to give 1 gram, and you need to teach them how to give them and dilute them. So they had to run around, and finally they were able to get it, and we gave them. So small things which just it takes more time to implement immediately. So that was the situation we came to know, in spite of the training, online training given during COVID. I think we faced the reality during this telemedicine. Now, lack of competence is one thing. As you know, that Nepal has more than 11,000 skill birth training conducted. In spite of that number, we still have some quality issues. We still have the issues with the knowledge and the skill. And due to that, so the telemedicine miss the tower problems. Sometimes the information provided, information received may not match, and that would, I would say, the limitation of telehealth program. And also, like, the experts need to know where to refer exactly. Although in the program it was given all the GPS, that kind of GPS data, that from this center to go to the primary health center, it takes 2 hours, or it takes 3 hours, or to go to district hospital, it is so many hours. But still, like, sometimes it is uh, hard to think and hard to remember where to send this woman at middle of the night. Now, challenges mentioned by experts also, like some said they were very busy, and some they were not able to receive the night calls. Some said it was, the family was disturbed. Uh, and then again, like somebody mentioned, that there needs to be some incentive so that the experts' response would be better. Inability to comply reporting. And they said, we cannot manage time for reporting. We already have very busy schedule. So these are the things, like, again, for in the future, if we do the robust research, I think this is the point. The recording and the documentation is one important aspect. We really have to work hard on that. Uh, Again, these are the common challenges. I'll just highlight: poor internet connection, I've already mentioned. Sometimes there's power cutoff, and some senior staff may lack the skills and insufficiently trained to manage software and devices. I've already talked about the clinical knowledge and skills. So these are the complicated cases heli lifted from the nearby district, which is not very far from Kathmandu Valley, but still there were no roads because of the broken bridge and so stuff. And this is like one of the women who, like, I was involved in the initial period of heli lifting, and we learned that although, like, there are 29 districts in the country in the government program, in the remote remote areas, the airlifting is available, but many people didn't know. And the district where we got this call, that district is not included in that list. But there was this note of gratitude is that because of the coordination of the district team and the ward and One Heart Worldwide. So they have just mentioned district coordinator Rabin Joshi and my name to say the gratitude that because of this, the woman's life is saved. So these are the two cases they had sent this note, and it was also published in the newspaper. And these are the couples who were referred untimely manner, and the operation was done. And after a couple of months follow-up, also the mother and the baby are doing fine. So to summarize what I have said so far, that there are many benefits of MNH helpline because the service provider who is all by herself in that remote area, she was able to call, she was able to get guidance, and she was able to manage cases. I think that was that really gave them confidence, and that really gave them like okay, I can do this kind of thing. And this increased the access of remote birthing center with doctors and timely referral and avoiding delays, and solves the problems and reaches the remote populations. And if they were managed in the same place, it saves transportation cost. And we already talked about the confidence and the skills of the nurses. Now, what are the lessons we learned from this? So we need to have a pool of experts. We need to strengthen that. And we need to have a dedicated experts, which should be who are willing to take calls 24 hours. And video calls can be more effective whenever available. And even I have had a chance to do video call in certain cases, and that were really helpful. Strengthening a referral, again, like the experts need to know where to refer. Coordination, collaboration with referral hospital is critical, and advocacy for reducing administrative procedure for heli lifting is it. There is a lot of bureaucratic hurdle. Maybe I'll discuss that in the question answer time. And the capacity of building health workers, refresher training is important. And then MNS helpline orientation also to be done, because many even service providers do not know that the airlifting services are available. And most importantly, documentation, improving reporting is important, because maybe for that there has to be some incentive to the experts, or some research assistants can do that. And most important thing is the drug supplies. The availability of essential drugs, especially life-saving drugs, has to be available, and supply should be there in the lower health facilities. So the limitations is that despite its benefits, telemedicine can be a double-edged sword, because sometimes then, even the service provider would be saying that, oh, I can talk to the doctor anytime. And then, but important thing is that they need to have further investigation, diagnostic test, intervention, and need hospital visits. Uh, COVID was a different issue. So what is the way forward? I think the Department of Health Services, Minister of Health, I think all of us, we need to collaborate. The collaboration needs to be done with Nepal Society of OBGYN, Perinatal Society of Nepal, Nepal Pediatric Society, because I think I already mentioned that we could not save neonates because they have a very small window period. So by the time we refer, the neonates were not saved. Collaboration with the referral hospitals is crucial. Um, Guidelines for telemedicine should be enhanced and implemented, like we have the written guidelines, but now it should be implemented in a systematic way. Sustainability of the program needs ownership by the local government. So this has to be taken by the local government, and the cases needs to be referred within the province instead of bringing most of the cases to Kathmandu Valley. And there are other issues why they had to be brought to Kathmandu. So the technology has a role to play as an equalizer in access to quality service. And these success stories, I think we need to share as much as possible so that, more and more people are aware, even the service providers, experts. I think all of us, we need to be aware that such and such services are available, and it can be done. It can be done without much, fancy technology. So what is the take-home message? Clinical decision making skills are important. I think where they get stuck is that, especially when they use the partograph, once the action line is reached, I think that is the time to start communicating. Not that when 1 or 2 hours passed and they said, oh, it has been so many hours that she's fully dilated, she's not progressing. I think that is why the timely clinical decision making skills really is important. Ecological belt, geographical constraints, cultural practice also play a role, because in Thai, what happens after delivery, the women are not supposed to go out in many places, like even the service provider go the home visit, they are not allowed to see, or there are so many cultural different practices which come to play. And healthcare, and again, like, this is one of the take-home message, is that given the support, given the good mentoring, the service healthcare worker can improve the management. And we need to be committed to the diversity, equity, and inclusion. And this funding can be replicated in similar geographical countries. Uh, but in future, I think we need to have the robust researches need to be done, especially the institute like Oxford. I think if you're coming to do research, we need to be more focusing on the various aspects of this telemedicine. Finally, I would like to say that telemedicine is not a separate medical specialty. On the contrary, it is a tool. But mentoring and proper case management can save many mothers and newborn in an emergency. This implementation is one that will continue to require attention to planning, procedures and processes, and thoughtful evaluation to ensure sustainability of telemedicine in obstetrics and gynecology. Thank you very much for your kind attention. I would like to thank One Heart Worldwide, Nepal Society of OBGYN, Nepal Public Health Foundation, and all district staff who were key to implement. And we spend many sleepless nights, but I think we work together, and we're able to save women, and that is the best part of this program. Thank you very much. Back to you, Kusum. I'll be more than happy to respond to your questions.
Thank you so much, Dr. Swaraj. And this has been really an exciting topic, and your findings are really exemplary. We do have questions on the chat box, but I was just thinking, like, if anybody wants to really have some discussion, I would love for you all to raise your hands, and we can then unmute you and have your questions directly. And I can also then take questions from the Q&A box. So anybody, you can please raise your hand, and Louis will unmute you.
Thank you, ma'am. So I've been unmuted. It was a wonderful session from Dr. Swaraj. Thank you for the insight. Like Dr. Swaraj had already discussed, that the major challenge that we face while we are providing telemedicine is the lack of medicines that I've already, myself practicing telemedicine, I have found it. One question that I'm very much interested is, at the current scenario, what are how many organizations in Nepal have been providing telemedicine, and what is the take of government? Because during the COVID time, we have been so much discussing about telemedicine and the budget that would be provided to every provinces. And we had a 12 pages guidelines on NMC for telemedicine too. But what are today's take? What are the processes that government is undertaking? Because I'm really unaware that government has been taking any active step, except I think for the foreign employment, telemedicine for the people who've been involved in foreign employment. So can you please provide insights on these things that are some dilemmas or the questions that I have found myself throughout the session? Thank you.
Thank you, Yege. I think that was excellent question. What you have raised is very pertinent. And One Heart Worldwide has extended the scale of this program in Karnali zone now. So if somebody is from One Heart, Sajna or Surya, you can even give your input. So there is a airlifting program. The government has this program in 29 remote districts, but very many service providers are not aware if their district is included in that program or not. Same is with telemedicine. Right now, what I showed initial photograph is that the between hospitals, I think there was telemedicine initiated by Mahabir Pun, and it was between some hospitals in Dhading, Hitaura, and Kathmandu Model Hospital. And we used to even do the talks in the international. But within Nepal, I'm not sure there is a systematic program like this, what we did during COVID. Okay, so this really is a kind of a what to say model we started that it can be done. If the experts are available, if the district MDGPs who are posted in the districts are available, if they are well connected, I think it has to be within the system, not like a always we need help from outside. This is simple communication, but I think the parties needs to be willing to talk, willing to listen, willing to give time. Now we have finished this study in 2021, and we analyzed and everything, but I still get calls, almost 2 to 3 calls every week, because I tend to attend the call. I don't work in the clinic in the evening, and I do part-time job in the hospital. So that is why I think it is important to be linking with the doctors within the district and their mentors, the SBA trainers, and it can be done. It's not a difficult task. It is not like a very rocket science. It is just asking questions and giving them instructions and whether they can manage there or send. So as far as I know, there is no systematically it is implemented, but we should implement this. Thank you, Yegi.
Thank you, ma'am. Just to add in, so like you've said that there had been some coordination with certain sectors, like in the area that I practice via telemedicine. Example, in Gorkha, they have this heli lifting program in Sirdivas area, and we have been able to save many pregnant women, and we're very happy for that. But the problem, what I see is, the success stories appear once, it is in the paper, and then people tend to forget it. And that's what I really wish the local authority be willing to take part ahead, like you've already mentioned before, take the ownership. And in that way, at least provide the medications. Like you've said, you didn't find tranexamic acid. It was the same with me too. So, and the problem is they had tranexamic acid, but in the local store of the municipality area, and they had to run in those on those hills. So yeah, these are the major challenge that I found. One was medicine, the other was training. I'm not very sure how updated we are with the training, but I guess that should also be looked into, and telemedicine should be complemented with our national medicine and should be streamlined is my take. So thank you for the wonderful insight, ma'am. Thank you so much.
Thank you
Yegi,
so much, Yagya, for your insightful and thoughtful discussion. We have Ephraim Ahmed, who has his hand raised, and then we'll have Professor Sanume Doli. So, Irfan, over to you, please.
Thank you. Do you hear me?
Yes.
Yeah.
Yes, we can hear you.
Yes, we can hear you.
I'm Ephraim from Ethiopia, Africa. So I have one question. I'm working in one of the biggest hospital in the country, in St. Paul Hospital, Millennium Medical College, and our hospital have a plan to start the telemedicine in our setup. So anyone to help me, I'm the leading person. So anyone have interest to work with me or uh, uh, especially for the organization and the experience sharing, please contact me. And if there is anything, please let me know. That's it. Thank you.
Ephraim, thank you very much for your interest, and I will coordinate with One Heart Worldwide, who took the lead, and also Nepal Society of OBGYN. Please send your email address, and then we'll get back to you. Is that okay?
Thank you very much.
Okay.
So, Irfan, if you can just put your contacts in the chat box, and this way, Dr. Swaraj and the team can follow up with you.
Thank you. I will do.
So now over to Professor Sanu Madoli.
Namaste. Can you hear me?
Yes, madam.
It is nice to see Dr. Kusum Thapa and Dr. Swaraj today. And I'm very proud and happy that Swaraj is doing such a wonderful work. And she also involved me in that One Heart program during COVID time. And I got not many calls, only 3-4 calls. But due to the poor internet, I could not communicate as much as I wish to. Now, my question is, now, have the government taken over this program, telemedicine obstetrics, in how many districts? And number 2, are they going to do regular update training for the program so that they will have successful result? After 2023, how much progress it has done about our telemedicine, which Swaraj has nicely helicopter lifted 2 people and like that. And once I heard in the news that when Madhav Nepal was coming from somewhere, he also brought 1 patient in helicopter, and they did a cesarean section for obstetric labor, and they had a safe delivery. Mother and baby were both safe. I read in the newspaper. I don't remember the exact date. Thank you so much, Swaraj, for a very excellent, informative, educational presentation.
Thank you, Dr. Dali, for your question. I think the 16 districts where One Heart was supporting, one thing which gives me really satisfaction is that initially there were many bureaucratic hurdles to do the airlifting. Ambulance and all is also not easy. It will take at least 2 to 3 hours to organize an ambulance to go to the hills and bring to the service site, to the referral center. But airlifting is also another challenge, because once we decide that this woman needs airlifting, you need to get certificate from ward in charge, and then you need to get letter from district office, and then need to coordinate to army for the helicopter. And this is not under Ministry of Health. This airlifting is with social welfare, Ministry of Women,
or Home Ministry probably.
That is why, and their timings are from 10 a.m. to 6 p.m., 5 p.m., and the obstetric emergency happens at night. And so there is a great disconnect between, while doing the communication. And we have had many sleepless nights, and One Heart played a critical role in this to do the coordination with these ministries and all. So we also spoke to Ministry of Health, Department of Health Services, that one person should be, dedicated person should be in Department of Health Services for this kind of coordination and communication. It's not always the partners, because ultimately I think it has to be within the district, within the province, it has to be managed. Right now the thing is that they have to be, we heli-lifted 20 emergency cases. 18 mothers were, we were able to save, but 2 neonates we could not, because of the, as we know, that the window period for the babies is very small. So this heli lifting taught us that there's a lot of bureaucratic hurdles. It takes almost 7 to 8 hours, because there is no night vision helicopter, so we cannot airlift at night. And most of the by the time the complication occurs, it is already midnight. So it has been a very slow process, but the bureaucratic hurdle has become less. Now, I think within 3 to 4 hours, we can do the airlifting. And this program is again scaled up in Karnali, like I had already mentioned. And this should be taken up by the local government. This is nothing like to impose, but in case of emergency, the lower cadre should be able to get the help from their mentor, from the district hospital doctor, and the provincial hospital. And also, I'd like to add one point here that regarding the neonates, I think it has to be the medical colleges who should have this NICU, because NICU is not available in district hospitals. So I think we really have a big challenge regarding the management of the neonates. So to respond to your question, Dr. Dali, it is not systematically there, but I think slowly and gradually people are understanding. Now those 16 districts which I had mentioned earlier, they needed our help, but now I think if there is emergency, they can manage themselves. So already ingrained in the system. So this is, I would say, the success of the program, that they do not call the One Heart Worldwide anymore. Even if some district they have phased out, but even when they are working, they do not get the calls. Now they are able to manage by themselves. So now it is being implemented in Karnali. Did I answer, Dr. Dali?
Yeah, so thank you, Suraj. I think you've covered it. So we have a question in the Q&A, and that's from Valentina. And Valentina, if you want to really unmute, you could. But the question Valentina has, and David, it's somewhat similar. What Valentina said is that is the MNH helpline was only accessed by health workers, or do women have also access to inform that they have an emergency or need support to travel to the health facility? And this is somewhat similar to what David has just mentioned. That is there a future plan for MNH app that these mothers can have? So over to you, Dr. Suraj.
Thank you, David and Valentina, for these excellent questions. Uh, I had mentioned about Mr. Rajendra Paudel, who has developed Amakomaya app, and this app is for the mothers. Once they have the app in their mobile phone, they can call the service provider, midwives or the nurses, skilled birth attendants, and then they can share their problems. Ours was a different motive, because during COVID they could not go to the health facility, or they could not refer to the bigger facility. There was lockdown. The transportation was completely came to a halt. So our our aim was different, and now in future I think these apps will be provided to the females, and then we'll have the record. And this we are doing study in Kapilvastu, one of the district in Lumini zone. Right now I think we are able to locate by GPS each and every pregnant moms in that district, and where the telephone call will be given to the local staff, that your EDD is now it's the time for your vaccination, it's time for your checkup. I think that kind of communication has begun, and in near future I think we'll have those kind of services. Thank you.
Thank you, Dr. Suraj. And I think one very important thing was regarding the incentives, the motivation for the telemedicine. I think those were things you brought up in your talk. And just following on to that, we have Lokinder Raul, who just mentioned that Chaya, I hope I've pronounced it right, Chaya Nepal is also providing technical support in telemedicine service conducted by Ministry of Social Development, Karnali Province, Surkhet. Given the rising number of telemedicine cases in Karnali Province, the current reliance on the hub center in Surkhet is becoming unsustainable. To expand consultation service, which institution or organization at the federal level in Kathmandu could serve as additional telemedicine hubs? Interesting. Yeah. Thank you.
Yeah, interesting. Like even if I said that it has to be within the province, but sometime it is not manageable because of the number of the staff available, the number of the healthcare providers. So it has to be like, if not in Surkhet, what is the next place? Whether it is Nepalganj or Sethi, I think there needs to be a good coordination where to send. And before sending, I think all of the team has to have a good understanding that which would be a good place to send. I think during this telemedicine, what we also learned that if there is no doctor in the district hospital, there is no point in sending in district hospital. So rather than send directly to the tertiary care center, I think these are the lessons learned during that study period. I can also see here Dr. Jitendra. He has mentioned that we have been using Project ECHO, Telementoring, Telemed, Tumor Board for cervical cancer prevention and gynae oncology in civil service hospital. Yes, excellent, Dr. Jitendra, for sharing this. Yeah, those kind of telementoring, telemedicine is for learning and teaching for the doctors. And so this is kind of, as an obstetrician, that obstetric emergency is something which is, we have to manage within 2 hours, within an hour, a fetal distress, immediately. So I think this is excellent what you are doing, but telemedicine for obstetric, I think it's a different scenario, as all of us we know. Thank you.
Yeah, so true, Dr. Swaraj. Obstetric emergency is sleepless nights. There's just one more question, which I think it's from anonymous attendee. I mean, it's not with the name. So during the course of consultation, do you consider including the concept of self-care for prevention of complications and promotion of better maternal and neonatal health? This is coming down to the self-care concept.
Yeah, I think this is from the preventive aspect, from the public health preventive aspect. We need to do a lot of teaching. I agree with you that self-care management, self-care component, I think that is part and parcel of our health services, where like female community health volunteers are doing this type of counseling. And now we have a concept of the community nurses who will visit and who will go. I think our postpartum visits have really increased because they also get some incentives, and they are doing these teachings. I believe I don't have the data as such, but they are doing these visits. Thank you. And it is important to do that kind of teaching. Don't you think, Kusum?
Yeah, definitely. I think we need to really think about a more systematic way on how we really integrate self-care into this whole telemedicine. I think that's also something, food for thought. Thank you so much. Valentina has another question, and this is really important and interesting, because her question is, did you find any reluctance on technology fatigue due to the use of the new system, especially when this was used after the COVID emergency? So, Dr. Suraj, any thoughts into that?
Reluctance or technology fatigue due to the use of a new system, especially when this was used after. What do you mean by technology fatigue? Like there is no technology as such. It's just the conversation by phone, and if needed by video. Like I mentioned earlier, even if now the study period is over, but I do receive calls from the remote part of the countries, because I think we have communicated so many times, and I do take those calls. So I don't think there is anything like fatigue. It is a continuous process. Let me put
So,
that way.
Valentina, if you are there, you can unmute and the floor for discussion.
Yeah, okay. Can you hear me?
Yeah, we can hear you. Yes.
Yeah, okay, thank you. So now my question is, yeah, I know it's just it's a phone call or a video call, but perhaps before this program there wasn't this sort of let's say continuous access to I mean this opportunity, and I was just wondering how health workers were feeling about I mean, certainly was an opportunity, but then on the other side is maybe using the phone or having the video call. Did they, especially after the emergency passed, so then you were in a different situation, and then you feel like, you know, I've done a lot of phone call. Were they already using it before for some cases, or was there any reluctance of saying, oh, should we continue this system? Is it really effective? So it just had kind of exploring their perspective in terms of, yeah, having this constant line available, but then how do you also take into account if some of them were maybe not that used to that? And as well, I'm thinking going forward, if you are using an app or another piece of technology, just to bear in mind this. And just to mention my interest is in this area, because the project I'm working is using a combination of phone and application to provide antenatal care services to women. And we have found that for some health workers, they were preferring to keep the system as it was, because it was maybe additional work, the fact that they had to phone call or to ask for advice. Even though it was useful, they still said, oh, this is increasing my time of work and I'm not remunerated. And so sometimes they were a bit reluctant. So that's just to give a bit of a context. So thank you.
Yeah, I think, Valentina, that is a very good point, because even our experts said that we don't have any incentive, so we are not like encouraged to do take night calls and all. And again, like in our profession as an obstetrician, we cannot say that either. You know, all the deliveries won't take place during daytime. So I think we have to be committed if we want to save women's life. So that is again like the personal interest. What you have pointed out is correct. Now, like more and more focused is on the woman side, because the app is being developed. And once they have an app, it's a very simple app. They are given the reminders and they can make a call to the service provider. And now the service provider are, when they are trained, they have a number of their mentors. When they are trained as the SBA training, they also get the numbers from their mentors so that they can call in case of need. I think the system will be shifted like that. So now this has given us an idea that how important it is to have a mentoring program. And Dr. Rajshri has sent a note that district healthcare providers need mentoring visits, and the mentoring and coaching is the part and parcel of the program right now. Many places we have mentors, and there is a simulation based training also. So she has mentioned that many cases are in Nepalganj Medical College are referred late because healthcare workers have identified high BP but are confused what to do next, since no one is there to ask. Telemedicine would bridge the gap. Yes, Rashri, I totally agree. If they have a mentors, if they have a place to ask, definitely they need to be they should get the treatment before they are referred. Okay, the staffs are reluctant to give Manx Self even after training, because I think it takes lots of guts to do all those things, and they need to have a medicine on hand. So you are right. I think mentoring is very important, and that should be done within the district health system. Thank you, Rajshri, for your input. Okay, Kusum, I think that's all.
Yeah, more or less, I think we've covered it all. And it was just somebody mentioning about the same which you've sort of covered, about what training was provided to these people when you started the program, like, because there are some SBA programs happening in the country, and so they have been trained, but not all have been trained as an SBA. So did you, did you identify the need for training? If so, did you bridge that gap of training, or what sort of induction did these people have on this, and for how many days?
So
And
these
the other question is, like, has this been published? And if so, you can share the link. These are two.
Yeah, the good news is that this will be published soon in one of the journal. So we have got the information that the article has been accepted. Once it is accepted, we'll share. Once it is published, we'll share. And now we have got the letter. It will be probably published in the month of February. Okay, so this is the good news I wanted to share. Regarding the training, these are the districts, Kusum, which the One Heart Worldwide is supporting. And there, like the nurses were already trained as SBA, whether they are ANMs, if they are if they are entitled to get training, they were trained. There was no training per se, but it was the orientation, how to, what are the scenario when they need to call, when they have like a prolonged labor or bleeding, all those complications which they have already learned during their training. So we didn't give additional training, but the orientation to everyone with all the OBGYNs of the NESOG, with the district experts, and to the nurses who are working in the district. Yeah. No training, but orientation. Yes.
I think for everybody to put that in the context is that these districts, which was the One Heart had already started working, and they were strengthening the skilled birth attendant services and training the providers as SBAs. So probably that's also something to keep in mind when we are expanding it into the other districts where there's been no training program, probably whether we need to build that in. So these are things I think probably need further discussion on doing this here, like, because all the providers were already trained as SBAs. It was easier for you to layer the orientation and layer the telemedicine, just as a thought for everyone. So I think we are almost at the end. If anybody has any questions, please raise your hand. This is a great opportunity to catch hold of Swaraj and really pick on her brain so that you can really use this opportunity. Anybody wants to ask any more questions? Okay, since we have no more questions, I would really like to thank each and every one of you all for your participation and the great questions. It was a great learning for everyone. Thank you so much for your participation in this webinar. And I would really like to take this opportunity.
Excuse me, ma'am.
Yeah,
Sanumaya Dolly ma'am is raising hand. I think she wants to say
I think that's
something.
a previous hand. We've had a question from her.
She had just messaged.
I think
Okay,
there was also a question from
Professor
Nat
Sanumaya Dolly,
Laxton.
please.
Yeah.
Over to you.
Thank you very much, Swaraj. I just wanted to share, since 1969, I came to Nepal to practice obs and gynae. And in 2000, when I was coming back from WHO meeting, everybody in the plane, they used to get so excited, what a beautiful Mount Everest. And they used to clap. But my heart used to cry because as Swaraj showed us those broken bridges, high mountains and all, our women are dying. And that time the maternal mortality was 560. And thank you, Swaraj. So today you let me know the maternal mortality has decreased to 121. So that was a great achievement of our country. And I'm very proud and appreciate all those people involved for bringing down the maternal mortality to 121. But I think still 121 is there, but there are many places where we could not reach. I think it is more than to 121 after the COVID. Am I right?
Yes.
Maternal mortality rate is more than 121 after the COVID.
Right now, the data we are using is 151, but various studies are showing it is 123, Raisa.
Okay, thank you. Thank you very much. Thank you.
Yeah, just one more thing, I think I missed, and because we have time, I want to hand over to Nat Luxton. If you want to unmute, or do you want me to just read your question? If you want to unmute, please, you're free.
Hello, can you hear me?
Yeah, we can.
Oh, hello. Look, thank you very much for your presentation. I'm actually in Australia. I'm a registered nurse and midwife over here. I'm just curious as to what the educational standard of your people who work at these small clinics is, because they've got such a huge responsibility, and it sounds like they do an amazing job.
Thank you for your question, Nat. We have a different cadres in Nepal. The lowest cadres are auxiliary nurse midwife who have got 18 months of training on midwifery after the school, like after grade 10. And so now I think it has been increased to grade 12, but most of them had the training for 18 months. But now I think this cadre will be discontinued in the sense that there will be no more ANMs produced in the country, because now we have changed to midwifery training. How many midwives are trained so far? About 60 to 70 midwives are trained in the country, but maybe half of them have already left. But I do work with the midwives since I'm the advisor of the Midwifery Society. So your question is very pertinent in the sense that with their limited knowledge and the skills, it is a challenging task for them to do everything, but they are supposed to do only normal delivery. If in case of complication, they have to refer. Like I said, just refer doesn't answer the question, doesn't save the woman. But then once they get the skill birth attendant training, which I think it has surpassed our need. Already 11,000 are trained, but these now we no longer give training to these ANMs. Rather than we focus on the staff nurses who are working in maternity care, who are trained for 4 years, and then they do manage the maternity cases. Okay, so two cadres. One is staff nurse trained in SBS, working maternity unit. Another is auxiliary nurse midwife. And most of these remote areas are posted, only these ANMs are available. So that is the tragedy of being in our part of the world. But then I think uh, they are, I should say, they are doing a fantastic job. In given their knowledge and skills, they are managing cases. And my experience with these girls during this COVID and during this telemedicine implementation, I think if they are well mentored, if they are, given the support, I think they can manage cases. At least they can identify and refer on timely manner. That is what I have learned. And I must say that, where the doctors are not reaching, where like a staff nurse are not reaching, they are providing services to our people. And ultimately, the future plan is that they will be um, probably used as a community nurses, and only the midwives and the staff nurses will be working on the maternal health. Did I answer your question, Nat?
Yes, thank you.
Thank you so much, Swaraj, Dr. Swaraj. I would like to just call Deepesha, to say a few words on behalf of Dr. Maskey from Nepal Public Health Foundation. Over to you, Deepesha, and then I'll
Thanks so
close.
much, ma'am. Hi, everyone. So I'm Deepesha Silpakar. I'm the coordinator for the Global Health Network Nepal Center. So I'm here to say something on behalf of Dr. Mahesh Kumar Maskey, who's the lead for the Global Health Network Nepal Center, and also the executive chair and founding chief of Nepal Public Health Foundation. Since he's not doing quite well, so I'm speaking on his behalf. We are really delighted to host the Global Mother and Child Hub. Thank you everyone for joining. Thank you, Dr. Rajbhandari, for such an insightful presentation. Thank you so much, Dr. Thapa, for chairing the session. And thank you, Ramila, and the entire TGH team for being such an integral part to to organize this session. So we have taken the responsibility of the Global Mother and Child Hub to create a dedicated space where we unite experts, researchers, and practitioners to collectively address the challenges on MCH health. And we aim to conduct these webinars bi-monthly and discuss different areas on the topic of maternal and child health. So I hope to see you all on the next one too. Thank you all for joining. Thank you, Dr. Thapa.
Okay, thank you, Deepesha, for your comments and encouragement. Just a few things is that like the Q&As and any other questions, which if we'll again go through it, if it's unanswered, then we will provide, Dr. Swaraj will be able to provide an answer to that and put it in the link which is provided by Lewis on the chat. The recording of this session will also be available to you all, and you can find that link on the chat. So please look at it and try to use that link. I would really once again like to thank Dr. Swaraj and all of you all for your participation, and most important, the Global Health Network and Nepal Public Health Foundation team who've worked tirelessly behind the scenes to make this possible. Thank you, everyone. Thank you, all of you, and we hope to see you all again. And this is just the beginning. So thank you once again, everyone.
Thank you.